Okay, so this is the second video. At this point, we've emptied out everything from the main compartment. This part here, I put in a bunch of disposable bear claw thick tactical gloves, ideally out of packed, like at least 30, but I think I fit about 10 in there. Ideally, those would be available somewhere like attached to the outside so that you can put the gloves on right before you even get everything else. And then this compartment will ultimately also contain the prolonged casualty care manual, and probably it'd be worth dividing it in half, and then the second half would contain all the tablets, so the non-IV medications, stuff like Tylenol, but even like oral antibiotics, some oral painkillers, a few other things should go in here, and those are all going to be flat tablets, maybe some capsules, but they should easily fit in here and shouldn't take up too much volume. That'll be one, then the manual over here, and then potentially more gloves or something else. Now this part here is empty. Like I mentioned before, you have these syringes. It would be good to have them, in this case it's a flush, they could be lining this area all around so that you have easily accessible syringes. But let me walk you through actually what we are using. So one of the first things you're going to get out from the kit is painkillers and sedation. So let's say this patient has been through the tactical combat casualty care phase. All that TCCC equipment is included elsewhere in the medic's loadout, and that's going to be things like tourniquets, immediate resuscitation, potentially the first few units of whole blood, either person-to-person field transfusion versus something that was stored, but more likely these field transfusion type situations, because in the future warfare environment, we're not going to have that much blood. We're not going to have that many resources like SOF have, where they've been coddled in comparison in the last 20 years to what came before and what's coming after. So a lot of focus will be on the like person-to-person transfusion, like Rolo and Valkyrie for the Rangers and Marines respectively. So at this point the casualty has gone through that. They've potentially been intubated. They might already have a chest tube in there. Now we're going on to the prolonged phase, and despite what the guidelines say, there's no idea, like no one really knows when this starts. You don't know if a patient's sometimes going to be picked up within minutes, hours, days. Plans change. Helicopters get retasked, shot down, same with ground vehicles. So what I think is going to happen is fairly early on, once you have a lull or you're further behind the forward line of troops, you're going to transition to this PCC phase. And so at this point, having said, so we probably already have given some basic painkillers, potentially intubated the patient, which is going to rarely happen in this context because it takes a lot of resources to keep someone intubated alive. And at that point, they would probably be triaged out, meaning that we decided we just don't have the resources to keep them alive. But at the same time, people talk about this a lot right now in the medical community. I think people be intubated and kept alive longer than we expect right now because you don't know how quickly people will be evacuated. You don't want to be the person to say, especially because you know the casualty often, hey, I said this person's going to die, there's nothing we can do. So if you have the resources and the manpower, the person power, this equipment, you're going to intubate them and keep them alive, at least for hours, to see if they declare themselves in terms of if their injuries are survivable and to see if evacuation can come. So one of the first things you're going to set up is these two, they're different colors, but in real life they ultimately will be the same. But these are ambit pumps, so you can run drips. And so one drip will be continuous fentanyl, which is both sedating and painkilling, and it's fairly short acting, so you keep it running. And the second is ketamine, which is the only authorized, really viable sedative right now, and it's primarily a sedative, but also painkilling, versus fentanyl, which is primarily painkilling, but also sedating, if that makes sense. You're going to probably end up running 2 IVs that you place with your TCCC equipment to run one of these each. Going with that, you are going to have some adjuncts, some second line stuff. So we're going to be packing a whole bunch of dilaudid one-time use syringes that you can just put in through an IV or piggyback. And so these, it's just, you just attach it to the IV or to the IV bag that you're piggybacking on, depress the syringe, empty it. But then you also need to flush. So every time you do any kind of IV injection, you're going to have to flush that with one of these. So it's especially coming from the physician world, being used to nurses doing this, it's a lot more complicated than it looks in terms of, oh, you just give that one syringe. No, you don't. You also have to use that other syringe. And we'll go into the flushes in a second. But yeah, so you've got fentanyl drip for pain control. Then you've got the diluted pushes additionally. Similarly, you've got the ketamine where you can adjust the rate as well and potentially increase or decrease sedation. But let's say some patients just don't respond well to ketamine, so you're also going to have lorazepam, aka Ativan, which is a little bit more complicated to administer. It's a benzodiazepine, so it's a good sedative. And one problem that we've discovered with these, and I'll go through this in a video after this, is these bags, you see here fentanyl comes as an IV bag, and similarly you can get and so that is great. You can just attach it and run it. Something like this is one step further, where you have to take the medication out of the vial, then put in a syringe and then administer it. So it's more complicated. And then I'll go over the ketamine in a second, because that's the most complex thing to administer right now, because there's no pre-made bags. All right, so you've got the lorazepam, and then this also needs to be to hand every time you give the lorazepam. This is a reversal agent in case you over-sedate the patient. So you start with pain control and sedation. Then one of the next things you're going to do is antibiotics. And one of them is an infusion, a slow one. Although we can have we'll have a pressure bag handy in case you have to do it quick for whatever reason, but you really don't want to do that with vanc. And then ertapenem, which is another medication, and this is another vial. And I'll go again through the administration of these vials in a minute. And then lastly, you have some TBI medications. One is Keppra, which prevents seizures. And then another is 3% normal saline when you're worried about brain swelling. Which is going to be a controversial inclusion in the kit to a certain extent, because once the patient has significant enough brain swelling, you're going to triage them out in this environment. And plus, if they're very sedated, it might be very hard to see what's going on. But this isn't the kind of scenario where you can do any kind of trepanation of someone's brain and decrease swelling. Lastly, for seizures, the Ativan also functions as a way to abort seizures. So this Keppra here prevents seizures. The 3% in a certain way would prevent seizures and brain swelling. But then this Ativan, you have to be able to give at short notice if you notice an actual seizure happening. So this is dual use. Then you have a couple extra medications that are just kind of general adjuncts, as we call them. So one is metoclopramide and the other one is Zofran or ondansetron. And you need to be able to give these if a patient starts vomiting. Which can easily happen not just due to injuries, but also as side effects of the fentanyl in particular. Then you've got something little like famotidine, which is a once daily shot to improve, or rather decrease the amount of acid produced in the stomach, which can improve patient discomfort and decrease certain risks. We might end up taking this out just because in the grand scheme of things, it's not as important as certain other meds. Then I'll go into the flush administration in a separate video, but essentially this is a big challenge because, as I mentioned, you're going to have to do a flush every time you put something in an IV. And so the way I did it was I set up 10 of these pre-filled flushes, and then once you run out of these, we're going to set things up so you refill these flushes using this 500 ml normal saline bag that you're going to have to hook up a thing to so that you can draw from it. But this seemed the most elegant way to do this, because if you can't have unlimited flushes because these take up so much space. But you also need something to hand, especially initially. So let's say start with 10 and then refill them from here. And then lastly, you have other equipment. So from right to left, ideally you already have given a couple units of blood, but here are 2 extra units that you can give via these transfusion kits. Then you have a naso or orogastric tube that you can do to decompress the stomach if someone's intubated especially, or if they're vomiting a lot, you can put it in through their nose even when they're awake. Then you have a chest tube, especially over time people can declare themselves to have blood and or air in their lungs, or lung spaces, not just one side but both. So we figured if even if they already put in 1 chest tube during the TCCC phase, they may ultimately need 2. So we added this one. That could potentially get cut later because this might just be classified as TCCC equipment. But regardless, you're going to also need suction to actually suction out what comes out of these tubes. And so this is a very basic suction device that you can use. Then anything prolonged, especially if the patient is unconscious, you want to be able to monitor their urine output, make sure they're having, it's sort of critical care 101, making sure they're having, the kidneys aren't getting fried, making sure also if they have anything keeping them from peeing, that their bladder essentially doesn't explode, that it gets decompressed. So anyone who's being treated for hours is probably going to end up with a Foley catheter unless they're awake and can pee. Then I already talked in that previous video about restraints. There should ultimately be 4 of them. And then I touched upon this stat infusion bag that literally just squeezes one of these IV bags to get fluid out quicker. Okay, so this is right now everything that we're packing. And now I'm going to finally repack these makeshift kits into individual Ziploc bags so we can have another look at them.